Welcome to Red Carpet Healthcare Solutions, hosted by Dr. Ryan Molli and Travis Buzzell. Join us on this journey as we educate the patient population, inform today's medical providers, and inspire tomorrow's medical leaders through education and in-depth discussions. We can all discover today's best healthcare solutions. Now, sit back and enjoy Red Carpet Healthcare Solutions Private Practice Podcasters.
Hey everybody, welcome to Red Carpet Healthcare Solutions Private Practice Podcasters. I'm your host, Dr. Ryan Molli, joined by my co-host,
Travis Buzzell.
And tonight we have a great guest. We've been trying to get him on for quite some time. We had some scheduling conflicts where we had to reschedule, but this is a private practice orthopedic surgeon up in the New Hampshire area. He's kind of an interesting character because when you think of joint surgeons, you think of mainly lower extremity, hip and knee. And then when you think of shoulder replacement surgeons, you think of maybe a sports guy or a shoulder replacement guy. But very rarely do you have a major arthroplasty surgeon that does both. And not only is he unique that way, but he's also done amazing work in kind of the private sector with bundled payments and things like that. And what better podcast to kind of feature somebody that has kind of thrived within his own private practice and kind of figured out creative solutions as to how to do that, especially with reducing reimbursements. So without further ado, Dr. Moby Parsons.
Welcome.
Thanks so much, guys, for having me. I'm honored to be on the show. And Ryan, I've certainly followed you on LinkedIn and all the great stuff that you've been doing down in Pennsylvania. So congratulations to the success that you've had. And I know we share a lot of the same interests when it comes to transforming musculoskeletal care in these somewhat challenging times with the way healthcare is going. By way of background, I grew up in Baltimore, Maryland. My mother was an orthopedic nurse. My stepfather was an orthopedic surgeon who was the fifth person in the United States that had a methyl methacrylate license. Back in those days, if you wanted to do total joints, you had to go spend time with Charlie. If you wanted to do total hips, you literally, FDA mandated that you went over, spent time with Charlie, and then got a license to use methyl methacrylate. So my stepfather had the fifth one in the United States and started doing total joints in the 1960s. Wow. So that was pretty cool. So when I grew up, I got to go into the operating room with him when I was a teenager and was just kind of surrounded by orthopedics at a fairly young age. And so that sparked my interest in it. You know, pretty much from the time I can remember, I was one of these people that I like to say I was brainwashed by my mother to go into medicine. And then it just became sort of foregone that it would be orthopedics, and never really hesitated, never really changed my mind. I went to college knowing I was going to do pre-med. I went into medical school knowing that I was going to do orthopedics, and never really wavered on it, and have never really looked back on it. It's been a great career. It's been something that I'm still very passionate about. I still love my job, which I think is getting harder and harder for a lot of people these days. But it's been a lot of fun. I was out in your neck of the woods for my residency at UPMC with Freddie Fu when he was chairman, and with JP Warner when he was the shoulder guy out there. And when I went to medical school there at Columbia, there was a very a marquee shoulder service there. And if you wanted to get in to the best residency program, you had to rotate through the shoulder service at Columbia, because they had Louis Biliani and Evan Flato, and they were the big name guys that letter of recommendation that could then get you into the residency program. And then when I went out and interviewed at Pitt, something just clicked instantly with me out there, and I was lucky enough to get in.
Do you know Sean Bach at all?
I do know Sean. Yeah.
Yeah. So I know Sean from, cause I was in practice in Michigan for about 5 years, and I did my residency up there, and Sean and I crossed paths when he was a young attending and I was a resident. I really enjoyed Sean a lot, learned a lot about him, and he always talked about Dr. Bigliani, and, because he was at Columbia for his would it have been his fellowship or his residency?
I think he did his fellowship there. Yeah,
Okay.
yeah. And so then I went out to University of Washington, did my shoulder and elbow fellowship with Rick Mattson, which is just an amazing experience. I mean, talk about a phenomenal mentor in every way, yet
Like the
beyond
Godfather right
orthopedics,
there.
just life in general. Um, and then I spent an additional 6 months doing a shoulder and elbow fellowship in Sydney, Australia. Just kind of one of those things where I heard that there was an opportunity down there. I submitted an application. I never heard anything for like 4 months. I completely forgot about it. And then I got this thing in the mail saying, "Hey, we'd love to have you come down." And at first I was like, I don't know. Maybe I just want to get out and start earning some money. And then when I started asking attendings who were 20 years in practice whether I should go spend an additional 6 months living in Australia, they were like, 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 what kind of question is that? You'd be crazy not to do that. You're never going to have another chance to do that ever again in your life. So I had two little kids, and my wife was pregnant with our third, and we spent 6 months down there, which was a lot of fun.
So you took the family with you.
Yep, yeah. And so I have pictures of my
Nice.
kids like standing on the steps of the Sydney Opera House when they were 3 and 18 months, and they have no recollection of it at all, which is unfortunate. But it was a really fun time. And then
That's
we went
awesome.
from there. We left there in January 2004 when it's like the height of summer, 99 degrees, and went directly to New Hampshire where it was probably zero with snow on the ground. And that was our transition into practice. Then I about 2 or 3 years into practice, the senior partner, who was a joint guy, announced that he was going to retire. And since I was already doing upper extremity joints and was one of the few people around doing shoulders, I just sort of thought maybe I'll take his practice. There was already some sports people doing sports shoulder and things like that. And so I just sort of morphed my practice into all arthroplasty, which is probably 95% of what I do now, and then some occasional other shoulder and elbow stuff that still comes my way. And so over the years, I've just sort of picked up the skills of doing some revision work and things like that, and now it's pretty much an all arthroplasty practice. And then probably
So when you first came out, Moby, in your first couple of years, I mean, early 2000s, was there a lot of arthroplasty then? Or were you doing mainly sports shoulder stuff and upper extremity stuff?
certainly it was mainly rotator cuff was probably the predominant thing. There was probably about 70 shoulder arthroplasties a year. This was when reverse was just kind of coming into the market. And interestingly, the volume of shoulder arthroplasties has gone up, but the number of cases that I do has been steady because there's so many other people that are now doing shoulder arthroplasty. So when I came to the area, I was the only one doing it, and now there's 7 or 8 people around doing it. And so everybody's numbers have stayed relatively flat because we're all just diluting each other.
Yeah. And then you added the hips and knees, as you mentioned, when one of the senior partners kind of decided to step away.
Yep.
And so currently, what would you say your breakdown is percentage wise of hips, knees, and shoulder arthroplasties?
Yeah, probably. I would say it's probably 40% knees, 30% hips, and maybe 20% shoulder. That math doesn't work out. 40, 50% knees, maybe 30% hips, and 20% shoulder. Something along those lines. Yeah.
Okay.
I mean, knees, I think just because there's so many of them to go around.
Yeah.
But I probably do 2 hips for every 3 knees that I do. So I do a fair amount of hips.
And your entire practice has always been private practice. Is that correct?
Yeah, so I was part of a larger group for the first 14 years of practice that was about, started off with about 6 surgeons, went up to about 9 surgeons. And that was fine. But mid-sized groups, I think went through a period where if you were small, it was okay. If you were super big, it was okay. This is when practices were coalescing. And I think mid-sized groups were the ones that struggled with overhead as overhead costs went up, as everybody migrated to EHRs and got digital radiology. And also just the resource needs, where joint surgeons have different resource needs than hand surgeons and sports surgeons. And when you're trying to be democratic about, about sort of all the things in a practice that you need to agree upon, it just got a little bit harder every year to do that. And so at one point, my local hospital contacted me about becoming an employed physician, and we looked at that option. And then another prominent joint surgeon in town who was basically solo practice, contacted me and said, I think it's time I bring somebody else in. You've already got an established practice. It makes a lot of sense for us to join each other rather than compete against each other. And so I joined my partner, Tom King, about 7 years ago. And it's been really great. He was really the one who was the first person in the area doing outpatient total joints. And so I was able to kind of leverage his expertise to make that transition into doing joints as an outpatient. And he laid a lot of the groundwork for the bundled stuff that we've gotten into, which has been a really fun project over the years.
What year did you say that was again when you two paired up?
2017.
Okay. So 7 years ago. Nice.
So how do you transition from, I know you were talking about, doing your stint in Australia. So obviously being from Maryland, being in Manhattan, Pittsburgh, all these areas like New Hampshire. So obviously, that's where we're at now. How does that happen?
Yeah. So I went to boarding school in New England. Both of my sisters had moved to the Boston area. I went to summer camp in New Hampshire and Maine. I'd spent a lot of time up here over the years. And, my wife is from Connecticut. And so when we were thinking about where we wanted to look, we sort of were thinking Boston to Washington, D.C., because we met in college at Georgetown. So we both had lived in D.C., both lived in New York. And that was sort of the corridor that we were looking in. And it's funny because I never really thought much north of Boston. I came from a very academic training background. There was not a lot of academic shoulder jobs available at the time that I was coming out. And so we started looking at private practice. And actually, one of my co-residents from Pittsburgh had joined the practice in New Hampshire. And I called him up mainly to get pointers on what kind of questions should I ask, what should I be looking for when I vet these places. And he basically said, we're looking for a guy, so why don't you come look at us? And we had never really thought about New Hampshire, but we came and liked what we saw. And it's really been a great place to practice, a great place to raise a family. So we're very happy here.
Is your practice that you were previously in prior to 2017, are they still in existence?
Yeah, they ended up becoming employed by the hospital, and then that hospital got bought by Mass General. So the Mass General Brigham network has sort of expanded out into, southern New Hampshire and all around. And so they're basically now employed physicians of Mass General Brigham.
Do you stay in touch with them at all?
A little bit. I mean, some of them I do.
Are they, where are they at with that transition? Because
are they happy is what he's asking.
Yeah. The $1 million question.
Yeah, I think, like a lot of these deals, I think it depends a little bit on where you are in your career. I think the older people are probably a little bit happier with it than some of the younger people. It doesn't provide some of the same opportunities to have ownership in a surgery center and sources of ancillary income. And so I think for the most part, they're reasonably content with it. Fortunately, we live in an area where the cost of living is not quite as bad as some of the big cities. And so I think you can still make a pretty good living. And honestly, I don't know enough detail to really comment on whether it's been a good thing or a bad thing or how many times they've had to renegotiate their contracts or anything like that.
So you mentioned that you kind of flirted with that. You considered hospital employment at one point. Obviously, your entire career has been private practice. I'm about as staunch as they get. I mean, I have a podcast with my buddy here called Private Practice Podcasters. So you're not going to find somebody that's an advocate more for private practice than myself. What is it with you that has kind of drawn you towards private practice, and what do you think are some of the main advantages, and what has kept you in private practice this long of a time?
Yeah, it's a little bit like fighting a battle, and it's a little bit unfortunate that it's become that way, but that's just the way it is with practice economics and overheads and reimbursements and the whole nine yards and staffing issues and everything that, everybody's facing these things now. But I think, the main thing for us is, it's nice to be independent. It's nice to make your own decisions. I think really what's been a lot of fun for us is this whole transformation that's going on now with this, direct employer contracting, with self-insured companies, with bundled payments. And that's a really neat opportunity, as these, bigger companies that have, thousands of employees all over the country, they can't afford to buy an individual policy for each one of their employees. And so bundled payments is a growing market. And we got started with that quite early and sort of figured out how to manage bundles, how to adjudicate bundles. And it's not easy, but just through platforms like LinkedIn, we've made a phenomenal number of contacts, of people working in this space. We've learned a ton about how insurance companies work, about the differences between how they work when they're a third-party administrator for a self-insured company, versus selling policies to just, average people who are purchasing directly. And it's a very complicated space, but the more you learn about it, the more interesting it gets. And by staying private, it keeps you nimble working in that space, which has really, been a lot of fun. And so I think that's kind of the main thing that gets us out of bed in the morning is trying to be part of this whole transformation that's going on in terms of the way that we deliver care. And so, it's a work in progress, but for us, I think that's going to be the future of our practice. I think we're always going to take care of Medicare patients because we want to provide service to the community, but that's not going to keep our practice alive. And this is what's going to keep it alive. And I think if you work in a big health system, they just have too much administrative overhead to be able to do it in a really cost-effective way, like a private practice can do it.
It's interesting too. I mean, kind of just hearing all the things that you're saying, it's like, to me, I can remember. So, my background is in like more DME and, med device distribution sort of stuff. And so, particularly with DME, as it relates to, where guys used to have, their own private practice DME, and then, they were outsourcing things, and health systems bringing, more of that stuff in-house, to avoid, certain cost centers and things like that. Like on the West Coast, I mean, I remember 10 years ago talking about, bundled payments and managed care with some of these Medicare replacement plans and things that they were doing, where they're essentially putting the onus of these cost centers and looking at, okay, how are you managing this patient's care? You're going to be responsible for the overhead, rather than paying this, and this, and, saying, okay, we're going to allot, each amount for, A, B, and C. We're going to give you this lump sum, but it's up to you to manage that payment. And like you said, in a lot of these big health systems, it becomes challenging because there's so many, different layers to that, to manage that, to where in private practice, I mean, it's very attractive because it's like, oh yeah, we know how to do this. This is what we do every day. We specialize in, these, 4 or 5 things, and we know how to manage this patient's care very effectively, but more importantly, maybe more efficiently, right? Because, there's not as many layers to that, and it's becoming, more attractive to payers to look at those sort of bundled payments because, ultimately I think it's more advantageous for the private practice, physicians in terms of reimbursement, but believe it or not, it's more advantageous for a lot of the insurance companies too, because quite honestly, those bundle payments are even lower than what they're paying on in terms of like a scale level that they're looking at, across the country.
I'm really interested, Moby, what you were mentioning about going to the employees, direct employer, yeah. Right? Like if you're talking to me or say another private practice physician, and to your comfort level, because I know you put a lot of hard work into this, what size company are you going to? How do you start that conversation? Because a lot of them probably already have benefit plans already in place with, say, for us, a UPMC or a Highmark. How do you even begin those conversations? Do you say, hey, we know you have X amount of employees? Because it's not like you can provide cardiac care or primary care. We're subspecialists, yeah. Right? You guys in your practice and myself in my practice, we do a very niche type of practice. How do you sell that? You
can't go to the company. I mean, it's impossible. You just don't have access. And the HR people in companies really don't have a clue about claims and what kind of money companies are spending. And you just are never going to get to the CFO, which is really who you need to get to. And guys like you and me, unless you have a background in accounting, are never going to have the kind of numbers that's going to make a CFO's head spin. And so we sort of beat our head against the wall for a couple of years trying to figure out when we would, try to cold call or send materials to HR people and self-insured companies around the state, why we would never hear anything back. And it's because it's the wrong people to talk to. And so I think the way that you have to get into this, number one, you can try to do, like Travis mentioned, I think you can try to do bundles with the commercial carriers like the BUCAs. And there is some growing interest in that. That takes just trying to find who the right person is for your local insurance company to reach out to that person and sit down with them and talk about the kind of quality that you can bring. Now, when you're dealing with a commercial insurance company, it's interesting because they're not as interested in quality as you would think, right? What they're interested in is a large network, right? So Ryan, let's say that your data on infections, readmissions, and patient satisfaction and your HOOS and KOOS scores are better than anybody else in the state of Pennsylvania. The BUCAs don't really care all that much about that, because what they want is a network that gets them the most covered lives, right? So everybody's happy when they get to go to whoever doctor they want to go to. So it's in the best interest for the insurance company to have the biggest network of providers. They don't really care if some of them are low quality and some of them are high quality, as long as they have a big network that captures all of those covered lives inside of their network. And so it's interesting because you would think that they would care about quality, but they don't care quite as much as you think about quality. And if you ask them, well, why wouldn't they want to just send everybody to the person that has the lowest complication rate? It's really complicated, and you have to do a really deep dive on the nature of how these insurance companies work to understand why they don't necessarily care about that. But when they're acting on behalf of a self-insured company, it's different because the money is coming directly from the company, and the company can mandate where their patients go. Companies do want quality because they're paying right off the bottom line. So it's a different calculus. And so what we've learned is, it's really hard if you said, well, you're never going to get to the CFO. So do you go to the plan designer? Do you try to figure out who the plan designer is for each one of these companies in your area? Very hard to do. It's like impossible to figure out who the plan designers is. It's impossible to get in front of those people. And so I think what you have to do, there's a growing list of companies that are getting into this space of brokering relationships between self-insured companies and physicians who can provide fixed price, transparent care. And these companies will vet your quality, so they can get your claims data. They can figure out what your readmission rate is and your, reoperation within 90 days and all that kind of stuff. And so they have some sense of whether or not you're a quality surgeon or not. They may demand to see some PROMS data as well. And once you can start working with some of these companies, that's how you can sort of get in front of the right people. But it's difficult because there's so many companies working in this space now, and they all have a different platform. Some of them want day of surgery. Some of them want 90 days. Some of them have their own nurse navigator. Some of them want you to navigate it. Some of them want to adjudicate the bundle. Some of them want you to do it. And it's really all over the place right now. So the model is just all over the place. And so, this is where it's a complex work in progress, where the space needs some consolidation and expertise around helping, physicians who are interested in this get into it and figure out how can you start doing this in your own practice. And I think that's one of the ways to do it, is to start out by working with some of these companies that are already sort of, trying to link physicians to companies and provide kind of a turnkey platform.
So they're kind of a middleman, so to speak?
Yeah.
And I think too, Dr. Parsons, your experience, I think a lot of what you're talking about too, like there's a lot of roadblocks, like regionally, right? Like depending upon where you're located, right? If you're in a more rural area versus, you're in a, major metropolitan area, having a lot of those dialogues with, like those, because a lot of those payers, right, are the administrators of the plan, right? Whether it's, Aetna or Cigna, or, I mean, there are probably some other more, larger private, groups that will do that. But from, those plans, feedback that I've gotten a little bit is like some of the insurance companies will kind of play that in network, out of network game, where like, so the self-insured groups are sort of essentially, they're kind of bartering with, the insurance company, or, with the health system of, okay, this is what we'll pay for this. But, they start to kind of give them pushback of, well, technically, you're HMO, PPO, PL, whatever, they classify it as, whatever that plan is, that, these out of network benefits, and this is going to be the cost to, the member, which is the person who self-pay. I mean, there are roadblocks, right? Like, depending upon where in the country you're at, it is challenging from that perspective, because a lot of the big payers and the big insurance companies are, I mean, they're certainly giving pushback on that because they want to try to reduce that as much as possible.
No, 100%. And like when these companies are working as a TPA for a self-funded plan, they're sort of caught in this funny world where they do want to save money for their employer, but they also want to sort of, incentivize themselves through commissions and things of that nature. And so, it's like a funny sort of situation where they have competing agendas to some degree.
Sure.
I think where it's a little bit different. I think it depends a little bit on the company size. So, it's one thing if it's a local manufacturing company that maybe makes parts for an automaker, and they've got 500 employees, but they're self-insured. Yeah, that's somebody who isn't going to, maybe understand all the nuances. But when you're talking about Hilton Hotels, Marriott,
Sure.
United Airlines, Walmart, Amazon, Boeing, these mega companies that have thousands of employees all across the country, they're starting to understand this, because as inflation has become a problem and the cost of healthcare has gone up, and MSK is almost number one. Cancer is number one right now, but MSK keeps going up every year in terms of their spend. And when they start looking at the numbers carefully, it's different, because they can go to their TPA and say, look, we're paying the money for this care, and we want our patients to go to Ryan Molli. Anybody who's in a 3-hour radius of Meadville, Pennsylvania, that's where we want them to go. We want high quality, and it doesn't have to be low cost, fair cost. They're willing to pay a fair cost for quality, particularly for these mega companies, because they know one infection, one readmission, can cost thousands of dollars. And when they can, find these relationships, they can waive copays. Some of these patients will still have a $7,000 deductible or copay. If you had to pay $7,000 out of pocket and you're working at Hilton Hotel somewhere, you're going to get on a plane and go to Meadville if it's going to save you, if they're going to waive that entire $7,000 for you to go get your knee replacement in Meadville, Pennsylvania. And so these are the kinds of things that are slowly starting to take shape. And I think that is a good entry point, is to try to, get in with these big companies first, because they can demand regardless. Like, I don't have an Aetna bundle right now. We don't have a bundle with Aetna, right? But if a company that uses Aetna as their TPA for their self-insured plan wants that patient to go to me, they can demand that the patient goes to me, because it's their money at the end of the day.
So Moby, just a couple quick questions. Can you explain what's TPA? Number one, just for our listeners.
Third-party administrator.
Okay. And isn't it interesting how you're talking about musculoskeletal costs are going up and up and up and up, but our professional reimbursements are going down and down and down and down and down. So what's the discrepancy there? I mean, that's going somewhere, but it's not
inappropriate care,
coming
wasteful care
to the providers.
There's still, unfortunately, a lot of inappropriate care. The most inappropriate care is in spine. I'm not calling out spine people, but it's just a fact that when you look at the number of spine fusions that are being done, and then people getting second opinions and things like that, there's a lot of probably unfortunately, some unnecessary care that's going on. There's a lot of wasteful care. Let's say that let's say that you have somebody that whatever sprains their shoulder on the job. They get a frozen shoulder. They go to urgent care. Urgent care gets an X-ray. Urgent care sends them to the local orthopedic surgeon. They see a mid-level provider who may be really experienced but misdiagnoses them as impingement syndrome, sends them to physical therapy. They don't get any better. An MRI is ordered. They get more physical therapy. They get a cortisone shot. They get whatever, blah, 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 blah. They kind of get misdiagnosed.
And the cash registers.
And they're just, And a lot of it is
Yeah.
just care that's sort of misdiagnosed, wasteful, mistreated. It's not really leading to the proper diagnosis and treatment. And so I think that remains a big problem. And so I think if there's a way to better engineer the care to get people appropriately evaluated, appropriately screened, and treated properly early, you can save a lot of money for these companies. It just needs a full-blown transformation.
Sure. One last question. I'm going to pull a Scott Sigmund here, right? My mom's watching this. So can you explain what like a self-insured company looks like? And what does that concept even mean? Because I think there's a lot of listeners out there that maybe don't fully understand what that company, whether the big guys like the Boeings, the Walmarts, the Sam's Clubs versus those 500 to 1,000 employees for somebody in Erie, Pennsylvania that's a local plastics engineering company. What does that mean to be self-insured?
Yeah, so basically what they do is rather than buying an individual insurance policy for each one of their workers, that's too expensive nowadays. So I don't know how your practice works, but every year when we have to renew, my practice administrator comes up to me and she goes, "Here's your options. They all, none of them are good. Pick the one that's least bad."
Familiar.
And you sort of, depending on who your broker is, they give you the options that are in the market, and you have to pick one, and they're all incredibly expensive. And we all have seen the graphs where the cost goes up 12 to 20% year after year. What you're responsible for your personal out of pocket, your family out of pocket, it goes up, every year. Last year, our full family, 3 kids, myself and my wife, our full family out of pocket was $20,000. And we used all $20,000 of it last year. It's just a funny year. And so, that just gets to be like unsustainable for these companies.
Sure.
And so even smaller companies now can say, look, rather than trying to buy a really expensive policy for each one of our employees, we will just pay for surgery, any kind of care, any kind of, pharmacy, whatever, physical therapy. We're just going to pay right off the bottom line. And so we can, we'll just write a check for it rather than running it through insurance. And so they can hire an insurance company to manage their plan. But in the end, the difference is they're basically writing a check for the care rather than the insurance company submitting a claim through a policy.
But you still have somebody managing it, right? It's not like my practice administrator that's trying to manage this self-insured group, or is it you could either
Most
or?
of them will have a commercial carrier acting as their third-party administrator for their self-insured plan, because otherwise you become your own insurance company. And, most HR people and CFOs just don't know how to do that. They don't know how to negotiate with pharmacy benefits plans and all these complicated things. And so that's kind of how it works.
Yeah, you'd have to, right? Because otherwise it's like you're just paying list price for everything, right? I mean, in this regard, though, there is some negotiation where it's like, yeah, we'll pay out of pocket, but we also want to understand, like, what exactly are you getting for that, right? Like, show me the itemization. And I'm being, a little facetious there, but I mean, seriously, I feel like in that scenario, though, where, like you said, those companies are so big, and why it works there as opposed to, the local, small business that still is, a 500 cap in terms of employees, like in negotiating that price and working that reimbursement down. I mean, that's where that pushback comes back, right? I mean, because that's the whole idea behind it. Yeah, we're going to save money, but if we're paying, like you're just an insurance company, not looking around and just, cutting checks, whenever people ask for them. There is some, of the art of negotiation that goes into that with the TPA, correct?
Yeah, and I think the really big employers, because they have so many lives, they'll cover not just the employee but the families, and when you add all that together, for these mega companies, it's millions and millions of people. This is why, particularly during this time of inflation, where costs have gone up for everything, and co-pays and deductibles have gone up. Literally, it's like as of this year, there's a tremendous amount of interest in these self-insured companies really starting to take a look at what exactly they are spending and how can they spend less money and get better care.
Yeah.
And this is where the quality factor is really suddenly starting to come into play, because they want to get their workers back quickly. They want to make sure that the complication rates are low, because that's what's going to kill their direct spend. And so it's almost like the floodgates are suddenly opening about these self-insured companies getting extremely interested in figuring out where they can align themselves, with providers across the spectrum. Now, the difficult thing for a practice like ours or like yours, Ryan, is that, like we're two of us, Tom and myself, and we do total joints. So we do basically like 3 CPT codes that we have bundles for, right? But these companies want a full basket of services. They want all of MSK. They want women's health. They want urology. They want primary care, GI, and everything. And so that's where it gets really challenging. Is like we can provide high quality joint replacement care, but that's like a drop in the bucket as far as what they need globally for cancer care, for everything, for the whole yards.
Yeah.
So you kind of talked at the beginning. By the way, why don't we do what I like to call Buzzy's beverage break? So unfortunately, Dr. Parsons isn't able to partake because he had surgery today and didn't make it home. We had some technical difficulties. He could have probably made it home, drank the entire bottle, sobered up, and then been able to start the podcast on time with our technical difficulties. And thanks for being patient with us earlier, Moby. But take it away, Trav.
Put me on the spot here. As I told him, I wasn't really a wine guy until I met Dr. Molli over here. So this is
and we're sitting in the wine cellar, which we got to do like a tour of this sometime, because people only see this, which the cool stuff's actually over there, Moby.
I got a glimpse of it earlier. It looked pretty bomber.
Okay.
My skin's normally not glowing like this. It's the lights that are hitting my face. So no, so this is an Orange Swift, one of my favorite winemakers, just in terms of like what I like to drink. I like bold. I like big. I'm not like a, watered down kind of wine guy. So this is a full body cab. And I think, Dr. Parsons, I think
this is Palermo.
This is Palermo. And I'm sure, I think the full body cab was maybe your request, but I've had it in the past. It's great. It's, we were talking earlier kind of offline. It's kind of like a blackberry aroma. It's oaky. It's smoky. It's got some chocolate notes to it. So for anyone watching, I'm not that technical when I drink it. Historically, if it's wet,
I think you looked up the description.
Historically, no, I'm like reading from the. Don't pay attention to the note card on the back of the bottle. No, it is. It's really good. And like I said, if it's wet, I'll probably drink it. So,
Moby, have you had the Prisoner?
I have not. No, I don't think so.
So another Orange Swift, and then he sold it. And
this is a good story. Actually,
yeah, it's a great story. So he sold the Prisoner, and he ended up. He had like an 8-year non-compete where he couldn't, do anything. So he was like, well, screw you guys. I'm going to make the Prisoner, but I'm going to make the Prisoner on steroids. So he named the replacement for the Prisoner, which to him is a better wine. And I would agree. I've had it. It's called 8 Years in the Desert. So that was his 8-year non-compete. But they're both really good wines. The Prisoner's good, but I like 8 Years in the Desert. But yeah, this is Palermo. It's a good one. It's been a while since I've had it.
Doc, you'll have to message us when you get home and get your bottle and let us know.
Let us know what your wife thought of it.
Yeah, it's already empty.
Exactly.
So, Moby, what I was going to ask you is, when we first started talking about this, you were talking about the mid-sized groups, you were talking about the large-sized groups, and then you and your partner, you're a small group, but you're very niche. Um, how was that unwind, right? Like when you went from that, how many guys were in your group, your mid-sized group? Were you about
Eight
eight or so?
8 or 9, and then probably
Okay.
like 6 or 7 PAs.
Did you have spine and all the
Yeah.
subspecialties
Yep.
covered? Okay. And how many employees did you have for that 8-9 man
I
group?
think we had
Providers
over
included.
60. Yeah.
Okay.
So we had billing in house. We didn't outsource billing. All that stuff was in house, and so it just got to be very expensive. Payroll. It's like any business. Payroll and health benefits are the number 1 and 2 spend.
One expense.
Yep. Same. And we have 5 physicians, one of which doesn't do surgery anymore, but and 2 are kind of part-time, but
Well, the one thing though, I think, Dr. Parsons, one of the things that you mentioned, kind of like the world that I came from, when we would negotiate these novation and like on these big
you
contracts.
just cut me off.
No, it's fine. I had a thought that I wanted to. So what you were saying though was like these big contracts, they want like more inclusive in terms of like the offering. So like in our world, it was like spinal bracing and these sort of things. And you didn't have a boot, you didn't have a cockapra splint, you didn't have this, you didn't have that. So it was very hard to get on those contracts because they wanted more of kind of like a global scale of offering. But for you guys, like being subspecialty, like having that bigger offering, like we have regional hospitals in our area that like don't do OB anymore because it's a loss
Yeah.
leader. It's like by being able to provide all of the things that they're looking for, it's almost impossible. I don't think you could do it.
Yeah, so we don't have spine. We don't have foot and ankle. We do some hand stuff. I just do hips and knees. My partner, Dr. Frendek, does hips and knees. We have shoulder expert, sports med expert, but those are pretty much what you guys do is what we do. But we have like 30 to 35 employees. So what is your employee count right now? You went from 60 something down to
We
how
have,
many?
I think, about 8 or 9 right now.
Okay, you're lean and mean now.
Yeah, pretty much. Yeah, we have. I have a PA. Tom has a PA. We have a part-time PA who just helps us in the clinic a couple days. We have 2 nurse practitioners that help in the clinic, and when we're in the operating room, they're seeing people and doing injections and doing pre-ops and post-ops and things like that. And both of our nurse practitioners are part-time. So between the part-time PA and the part-time nurse practitioners, it sort of fills in the schedule. And then we have, front desk. Each of us has a surgical scheduler, and then we have, 2 part-time
X-ray
rad
tech.
techs. Yeah, and that's
Okay.
pretty much it. We outsource.
Do they function like medical assistants too?
Yeah. Everybody
The-
sort of
the
cross
X-ray techs?
covers and does some of the pre-certifications and chart prep and all that kind of stuff. And so everybody wears a couple of hats. So
You do out of house billing now?
we do. We send it out. Yeah.
Yeah, we
Yeah.
do as well.
So I think that reduces some of your FTEs, but it's still hard. Even though we're relatively lean, payroll still can be tough. And so,
How many surgeries do you and your partner do per year combined?
last year I did close to 600, and my partner is 73. He's in amazing shape. He has a really amazing practice where he basically does 1 clinic day a week and fills his surgery schedule out for months. So a lot of people go to him specifically when they say like, okay, I've been somewhere else. They told me I need my knee replacement done, and I'm here because I want you to do it. So he has a really sterling reputation for particularly knee replacements. He's like the knee whisperer. And so he operates 2 days a week, 1 at the hospital, 1 at the surgery center. He probably does, 400 plus cases a year.
Okay, so you guys are right around 1,000.
Probably, yeah. And it's funny because New Hampshire is the 4th densest per capita concentration of orthopedic surgeons. So it's a very competitive landscape. There's only like 1.2 million people in the whole state of New Hampshire. And so it doesn't take a lot of orthopedic surgeons before you're really kind of competing with each other. particularly for things like joints, where there's just a finite number of them to go around because we don't have a huge metropolitan area. I mean, Portland, Maine has got its own practices up there. It's very saturated. Boston's very saturated. North Shore is saturated. And so New England tends to have a high concentration of orthopedic surgeons. So it's hard to get, it's really hard to get a volume of 800 or 900 joints in a state like this. It's just not enough people.
Sure. I guess my point is for, the other surgeons out there that are either in private practice or looking to become a private practice, either out of training or maybe making the switch out of hospital employment, is trying to find that sweet spot, right? Like, do you want that 1-2-man group? Do you want that mid-sized group? Or are you looking to join that super group? And I think there's advantages, disadvantages to each of those. But I really like the model that you've kind of created where you've really made it lean and mean. And you were able to successfully kind of unwind it from where you were with 60 some employees with just outrageous overhead, which is what a lot of these groups are experiencing.
Yeah. I mean, the other nice thing is because my partner and I pretty much do the same thing. He doesn't do shoulders anymore. He used to do some. From a resource utilization standpoint, our practices have the same needs. You know what I mean? So it gets you away from those conflicts that groups can get into, particularly 5 years ago when joints weren't being done at ASCs and the sports guys were like, really killing it at the ASC and the joint guys were taking everything to the hospital. And it just created a lot of strife in these groups. And so for us, it's nice because we don't really have to compete with each other. We both, been doing this long enough that we have our own practices and we can really kind of standardize the way that we do things in terms of delivering the care. It just makes it easy for the people in our office to know that we kind of do it relatively the same way with a couple of minor twists, but not much. And that just makes the day-to-day operations pretty easy.
Oh, 100%. We do the same thing. It's just like we never wanted to have the Dr. Frendeck way and the Dr. Molli way with hip and knee replacement because it gets too confusing for staff, too confusing for patients. And then it creates internal animosity and it just is not healthy.
So I had a quick question. I know what it is in our area, but for you, like, what's the ratio private to employed, like in your neck of the woods in New Hampshire? Like, are you kind of like, a unicorn or
we are? We're the last private practice in Northwest Pennsylvania.
Yeah.
We still have some private groups around, but most of the private groups around have co-ventured on surgery centers with their with the hospital. So there's a private practice like 2 miles away from us, and they kind of co-ventured on a surgery center with the hospital. And that kind of puts them in bed with the hospital. Like it would be very difficult for them to do any kind of bundled payment stuff because the hospital is just trying to maximize their fee-for-service contracts at that surgery center. And so they're not interested in doing that kind of stuff. There's another group in Concord that's pretty much the same way. There's a large group in Manchester that's still private. And then as you go further up into the North Country of New Hampshire, those are mostly smaller groups, and they're a mix of private and self-insured. So we still have a fair number of private groups around, but a lot of them have sort of aligned themselves, with the hospital in town.
Is your ASC owned just by you and your partner?
It's multi-specialty, so there are probably about 10 people in it: ophthalmology, GI, ENT, plastic surgery, orthopedics.
Okay. Do you do 100% of your stuff there?
No, I still operate. I have one full day in the ASC and one full day in the hospital. And then every other week I'll have a second full day in the hospital. And so that's just kind of how it shakes out. And so I think we'll try to, but right now the ASC is pretty much maxed out in terms of its volume. There's no more block time there. So if I wanted to say I've got more cases to bring there, I would have to kick somebody out.
Can you expand?
They could. They actually put in a new room just this past year. They went from like an endoscopy suite with 1 room to 2 rooms. So now we can run a flip room there. And they probably should have shelled out a 3rd room when they did that, but they just, weren't thinking about it at the time.
Yeah. Monday morning quarterback, right?
So, I mean, I guess from in terms of kind of some of the stuff that we're talking about, one of the things that just resonates with me for, guys that are either in the employed model and they're looking to, jump over to, explore, private practice, or, I think and I don't know, Dr. Parsons on your side, but I mean, we've received like a ton of feedback and people reaching out that are like kind of at that crossroads right now. Like, okay, I think I want to go to private practice, but there's the burden of this and that. And maybe this just seems easier to go this route. Like, if you were talking to somebody who was like at that crossroads, right? Like, I think, and it's kind of funny now that I'm looking back at the catalog of all of our episodes, like the bundle payment thing we're talking about now, like that to me is just like a key component of like
Yeah, it's
succeeding, right?
huge.
And you don't have that option, right? When you have those kind of, you're tethered to that hospital or that health, you just have a lot less autonomy, which I think is the ultimate theme of private practice, right? Autonomy, in order to kind of get to where you need to be. But if you were having that conversation with somebody who's like, Dr. Parsons, why private versus employed? What would your message be to them?
Yeah, it's funny. I was talking to Stefan Kreutzer about this the other day, and he actually had a comment on LinkedIn. I don't know if you saw it, Ryan, where he basically said, "Look, if you don't, personally own or are part of a group that owns your own surgery center, forget about private practice because the economics of it don't work. And even if you're, co-opted with a hospital and they own 51% of it or 62% of it, it's just not the same. And so that was sort of his shake on it was like, if you can find a situation where you can have a major ownership stake in a surgery center, or like a specialty hospital or something like that, then you should potentially consider it. But otherwise, just like cut your losses and go work for a hospital because that's where it's all.
Cut your losses, sell your soul to the devil,
Yeah.
start flipping burgers or making pizzas because I did it for 2 years, Moby, and it was the worst 2 years of my life. It was my second and third years. I was private practice my first year, employed by private practice. Then my second and third years, I decided, hey, I'll try this out. Literally the first week, I had a 2-year contract. I knew my first week it wasn't for me. It wasn't even like, I'll think about this. My first week, I came home and I'm like, yeah, I'm going to fulfill my 2-year contract, but that's it. Literally the day that it's done, I'm done with this and I'm never doing this again. And then if I had to, I would find another occupation outside of medicine because it doesn't work for my personality. It doesn't work for my brain. It doesn't work for my entrepreneurial spirit.
I think that's the key.
That's my message for young guys coming out is like,
I think a lot of people, coming out nowadays like the potential security of going into a hospital employed situation where it's a guaranteed salary, moving expenses, whatever, loan forgiveness and the whole 9 yards. And I think there's something to that. The world's increasingly expensive with inflation, and it's nice having a guarantee. The super groups probably can provide a really nice upfront package for people because they have the resources to do that. But they have their own kind of headaches. As these groups get larger and larger, they get harder to manage, and they have a lot of real estate holdings and things like that can end up costing a lot of money. And so, you can grow too fast. That's one of the things that's happened to a couple of these really large groups is they've expanded too quickly. And then all of a sudden the economics don't work out anymore as they keep adding physicians. And so I think you have to be a little bit careful, on the super group side as well. And so, it's interesting when I was looking at hospital employment, that option was thrown at me. And then Tom called me up and said, do you want to think about joining forces? And basically at that point, I was 14 years in, and he said, look, I can't support you. You're going to come down here. You're going to have some type of, non-compete. You're not going to be able to take records with you. You're going to have to get up and running. And it wasn't that far down the road. It's about 15 miles down the road. And so it's the same geographic area. There was I was like saving for my kids' college at the time. And so there was a little bit of the stress factor involved in like, I've got to basically get this whole thing up and running again and get busy. And I said to my wife, I'm really torn here because if I go to the hospital, it's just a guarantee. If I go join Tom, I think things will probably work out, but you never know. And I thought my wife all day long was going to say, just go with the hospital, take the guarantee. It's easy money. And, you just show up and do your whatever 8 to 5 and you're done, collect a paycheck. And actually, my wife was funny because she said, look, I don't want to have to listen to you complain every day when you come home and you bitch about how much you don't like, working for the system. So like, that's just not going to work for our marriage. And so I think you should go work with Tom. And I was sort of shocked to hear that. But it was the right decision, I think, for me. And I think what you said, Ryan, is the kind of entrepreneurial spirit, I think, is a big part of it for us. And the whole bundle payment thing really caters to that, because there is this kind of care transformation going on. And, the amount that we've learned just about how the system works with insurance companies and bundled payments, and just the number of people that we've met and interfaced with that are working in this space has been tons of fun. And all of it's been through kind of LinkedIn, which is how you and I met. And, that's been an amazing platform just to make connections with people and sort of find out what other people are doing. And as you know, sharing cases online and hearing about how other people solve these complicated things has been a ton of fun.
Oh, it's been awesome. Yeah, I mean, one of the last things you're talking about the hospital employment, and yeah, the guarantee is great. And quite honestly, I think it's a personality thing. Like, some people that works better for them. But to me, the one thing I always looked at, and what I've continued to hear from these individuals that have been private practice and then went to the other side, it's 2 years, 3 years, and they're absolutely miserable. Yeah. And there are a lot of handcuffs that come with it, right? Whether it's a non-compete, whether it's, all right, your 2-year guarantee's up, we're going to reevaluate your salary, and your RVUs, your target's now going up, right, because we're getting reimbursed less, even though the insurance company that owns the hospital is also, that's a double standard. Yeah. So it's just like, to me, it's like putting the frog in the pot of water, and you're turning the temp up a little bit every year, and you don't realize you're getting cooked until it's too late. Again, for some people, that's okay. I think for academics too, it's definitely a better situation and setup. But for individuals like yourself, myself, that have more of that entrepreneurial spirit, more of that want to do things the way that they truly believe is best for their patients. Because let's be honest, I don't think that the hospital systems and the insurance companies, as we talked about earlier, have patients' best interests in mind in terms of quality of care and things like that. But to each their own.
Well, I mean, it's funny to me too to kind of hear you guys talk. I think one of the main kind of themes in all of these, Dr. Parsons, I've listened to another podcast, and Stu Brandon, other guys that, you've kind of put me onto that I've listened to. Like, the one theme in like medical school or residency, it's like, there's not a ton of, like, if I asked you, how much do you think this reimburses for? What, like, there's not a whole lot of like business acumen associated with, it's just like, you're really good at replacing this joint or, managing this patient's health, all those sort of things, which is really important. But it's funny to me, the more conversations we have and the more tethered the practitioners get to the economics, the more efficient and effective the care gets. But it's like, they're wanting to go in the polar opposite direction. And it's just like,
as Marty Nichols pointed out, do you know Marty?
Yeah. Oh yeah. Marty? Yeah. I know he was just down
so Marty, he recorded an episode. It hasn't come out yet, but he brought up a great point. He goes, in medical school and all these people, they don't want us to know much about business, because at the end of the day, who in their right mind would go into the hospital at 2:00 in the morning to fix somebody that was in a motorcycle accident when they were drunk, that doesn't have insurance, so you're not going to get paid for it, but you have to go do it, right? Because that's your obligation. Like, that's a really bad business decision.
The liability and everything else.
You may choose to do it because you want to help the person out, but at the end of the day, you're not getting paid. The liability is through the roof, and they're not going to be grateful for it.
So if I can ever get my practice to be 100% at the surgery center, then, guess what? You can come off the call schedule. That's my 2-year goal. I tell my wife, my goal in 2 years is to be 100% outpatient, like maximize the bundle, relationship.
Oh, you got to get there, Moby. I haven't taken calls since 2017, and 95. This week is the first week that I can remember that myself and my partner will have done 25 joints this week, hips and knees, 100% outpatient. Now, that's, assuming that they all go home. That we have a surgical hospital, so we do have 10 inpatient beds. So if they have to stay, it's not a big deal. But this is the first week that all of them have been slated or planned to go home the same day.
It's awesome.
You got to get there. Yeah. So closing thoughts, Trav, any final questions?
Yeah, no, I mean, Dr. Parsons, thank you so much for coming on. And I mean, it really is a testament to you guys, by, sharing your experiences and having these conversations. It's just like, I think we've identified that there's a problem in terms of like healthcare and insurance and, patient expectations and all that sort of stuff. And by just like uncovering some of this stuff and having a dialogue about it, I think it's super important because, there are, guys and girls, or men and women rather, just like you right now where you were, 10, 15 years ago, thinking like, what's this going to look like and where am I going to go? And, getting drugged from Australia to New Hampshire, or, from Michigan back to where you grew up. It's like there's decisions to be made. And like, to me, just humbled to be a part of, the conversation and the content that, brings this information to people who I think have been desperately looking for it over the last several years. And like you said, these platforms that have kind of connected, all these people to start having these conversations. I think it's great. So yeah, thank you, Dr. Parsons, so much. And taking the time. Sorry again about the hiccup earlier. We could have been done with this a little while ago, but thank you very much.
It's kind of fun talking off the record, I think.
Definitely. Yeah.
Yeah, no, it's, I mean, I agree. I mean, for like, thank you guys for having me on. And I mean, I think, there's a lot of smart people out there, and it's fun to have the opportunity to always be learning something new from smart people, who have a background in something that's different than what you do, but it intersects what you do. And then you get to see the whole other side of things. I do think we're in the midst of a really interesting period where there's a lot of sort of cool transformative things that can happen. A lot of it is sort of hasn't shaped itself out yet, but I think with the right people, it'll be, I think the next 2 to 3 years is going to be really interesting, and potentially it could be a lot of fun. I think there's a lot of problems, but we also know that there's a better way to do things. And it's just really a matter of trying to figure out how to scale that. We can do it in our own little silos and our own little regions, but we need to figure out a better way to scale it with people like Marty, like you, Ryan, who's interested in a lot of these types of topics. I know there's a lot of other people that are interested, and then just finding the right people with the business sense, with the plan design sense, who have worked on these things, and to try to just coalesce it.
I mean, that's the whole goal of this, right? Is you can find 100 people and get 100 complaints or problems, but come talk to me when you have solutions, right? That's the title of this podcast. It's Red Carpet Healthcare Solutions. So, again, thank you for your time. There's a great book that I just read for the second time. It's called The Obstacle is the Way by Ryan Holiday. I don't know if you've ever read it.
Put it on the list.
It's a fantastic book. It's essentially a book on like stoicism and learning that these problems that present themselves, most people would look at them as, oh, this is an insurmountable problem, the healthcare insurance issues. I'm just going to throw my hands up in the air and just give up, right? I'm done. I'm out. I'm going to find a new career. Where I think the problem solvers like yourself, myself, the Marty Nichols of the world, we look at this as an opportunity to make lemonade when we're given lemons. And I truly think that it's about your outlook and getting creative and having these really, really deep conversations, both on and off the record, to kind of stimulate one another and just continue to kind of forge ahead together. Right? And I think that's kind of what you're saying too, is like, we can come up with our own little individual solutions, but it's kind of that old adage, like, alone we can go fast, but together we can go far. And, I just want to thank you, Moby. This has been a lot of fun. I now have your cell phone, so look out, because I would love to connect with you, maybe off the record a little bit more, and just share a little bit more of each other's experiences. I want to hear how you like that wine, too, by the way. So
I'll have my wife text you later.
Smell of breath. That'll be the closest you get to tasting it. But and for all of our guests out there, I just want to thank you for tuning in. Obviously, If you have any comments, suggestions, please leave those. We're always looking for new guests. Moby, if you have any people that you think, Marty has actually already, kind of recommended 2 people that I think will be absolutely fantastic on this podcast. And again, it's trying to find those people that can help promote different angles for preserving private care and promoting like private practice care.
Yeah.
So
everyone, thanks for tuning in. Topics, things you guys want to hear about, again, guests, things like that. Shoot them our way. Outside of that, buddy, thank you.
Yeah. Thank you, Moby.
Dr. Parsons,
Thank
I
you, guys.
appreciate it so much. Thank you.
All right. Have a great night. See you soon. As a disclaimer, this podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professional from any such conditions.